mean, as I mentioned, for me, if we have 1 or 2 deliverables per group is already enough, knowing that for each of those deliverables that I just listed now, there are a couple of elements that we try to compile. And what will be important is that if something does not exist and we need to create it from scratch, like the curricula, but even the curricula, you're not starting from scratch. You have a lot of curricula that exists with more adaptation. But if there are things that really we lack information for, we need to know it because maybe we need to plan into our budget that, okay, this is maybe require some consultancy, some specific work, and a contract that we, the lecturer, might manage. Or if you need another meeting or something like that, these are things that require a lot of planning and resources that are not there. But I assume that many of the deliverables is mainly the work of the network itself, and if there is an assistance to be requested, maybe we need to flag it in the resource needed. For the policy brief, I'm not sure that we need additional resources, mainly about compiling what we have, but we might need someone that put together perhaps those 8. So we might flag whether there is a need for consultancy, maybe to put together or to support the development of the briefs.
We want to have also like a person or someone in the room that is responsible for the respective.
First, any comment on what I mentioned, and then in the groups, I mean the group in general, not necessarily our group or the policy one, people that's okay, this is something I'm interested to contribute to, and I can be part of that specific group that will be responsible for putting together groups. You're nodding, so say yes. Okay. Smiles from that, I mean, of course, we mentioned the aspect yeah, to review, you mean? Yes, there is a strategy.
Strategy in each.
Could you share?
Okay, she was asking whether the responsibility of this group would be to develop a strategy for each of the country. My answer would be no, because the strategy at the country level, as I initially mentioned, all planning activities at the country level need to happen at the country level. What we are of course, I mean, we are all the overall, I mean, goal of this is to make sure that palliative care is better integrated at the national level through plan strategies. But my point is that what is collectively at a regional level can be done. We can support through, I mean, we can imagine that some aspect would be technical assistance with some of the experts being mobilized as part of the policy dialogue at the country level, when you might say, okay, in Sudan, this is the right time, there is a request from the ministry, I need to have some backup of people that might be, I mean, experts in palliative care that I can bring for technical information. But this is, I mean, something very, I mean, episodic that we can arrange. It's part of maybe the policy dialogue. But what I wanted to see emerging is more what are the kind of concrete deliverables that the group can come out with. That could be products in terms of training, in terms of document, in terms of publication, no matter whatever, that we could put in place, I mean, together in the coming 2 years.
So for the policy briefs, you mentioned the consultant.
Yes.
That would help to do it, or?
More or less. I mean, this is also for the people, if they have just Professor Harding in this group developing the policy brief alone, it will not be possible. So I might need to have some people reacting from the group. Okay, can we be part of this? Do you feel comfortable to contribute? I mean, someone perhaps more on the aspect of opioid and the survey that might fit into that.
Could you say 1 or 2 sentences about what you foresee as being in the policy brief or policy briefs? Is it more than one?
Yes, I mean, this is something that needs to be discussed. You might have one that say situation analysis in general in terms of burden of palliative care and estimates of the need in the Eastern Mediterranean region. What is the current capacity and what do we see as emerging models or whatever exists there? What are the restrictions and the barrier, including opioid access to medicine? What do we see as part of this group the main recommendation that we commit ourselves maybe to support in the coming years. And it would be 1-2 pager. Or we have something that would be one generic that give a kind of overview, and then you can have a set of thematic, specifically on opioid aspects of service delivery model that basically would highlight the work, but by themes as we mentioned them. It's okay, training. This is the situation of training for palliative care in the AMR. This is what we envisage to do, is to compile a set. It could be, something quite, it's a brief, with the kind of key messages for action for policymakers.
But one of the products also from the opioid price watch is also a brief, correct?
Yeah.
So that would be another.
But the group would figure out what are the key messages that from a policy perspective we'd like to address, whether we go on one or multiple policy briefs in a kind of brochure together, and what are the inputs to be able to design those policy briefs. Do we need information from where? Can we compile? And who is going to do it? Can we do it internally within the group? Or do we need to hire someone that help us put together a first draft, and then we can review it together? This is, Charlotte, you're a bit used to the processes of...
Yes, I think we can definitely rely on us, and in any case, it's important because this group has the motivation. We should not forget resources like collaborating centers, which is actually representing one of the collaborating centers for palliative care. As you know, WHO collaborating centers work for the whole organization, so they're not specific to one region.
So when is the redesignation?
So, Sharon is the focal point, so I don't want to go into a conversation with him, but you can definitely include this in your work plan. And I'm also including NGOs in official relation with WHO, because this is definitely part of the work that can be done. Now, maybe a consultancy can be useful once we know exactly what we want to
the outline.
To wrap up and to consolidate. But I think we should start with valuable resources in the group, because if not, it might also, well, I don't know, maybe in Angle we can have something like this. For us, it's a little bit more difficult.
No, if I have the resources, of course, some consultant would require 1-2 months to get some of the contracts, things like that, but we can, imagine that we have in a PW or short-term consultancy to do the job. The question that I would like also somehow to test the network is, okay, if you are committed, what can you do about it? And then if we can facilitate, but I think the problem is that if for each activities you are saying we have a consultant, then, I would say, what is the point of having an expert network mobilized if basically it's my work plan that I have to execute through consultancy? But for some aspect, I think we can have a mixed blended approach.
I think if we're going to take the step of dividing up tasks and assigning people to tasks, we need to be more clear about what we're looking for in terms of policy briefs. So if we have one big policy brief, it's going to be difficult. But if we have the other approach, when we said we have a brief on opioids, a brief on human resources, a brief on services, if that's what we choose, then people can commit to that. And maybe then you can say, by the end of 6 weeks, I want an outline for the brief, and then you set that timeline, and it makes it easier. I think as things stand right now, we could do this or this or this. It's going to be difficult to get commitment from the group.
But this is a decision that needs to be made over now, or at least a subgroup might decide that this is the proposal that we make to the larger group, that most probably it would be difficult to get in one policy brief everything. What I was thinking that perhaps in a small brochure, you could have something that just outlined the overall approach of this initiative, and then you might have a set of 2, 3, 4 policy briefs that actually complement this, and then It's kind of small package that you can land and give it to any, policymakers at the national level or at the regional level. The other strategic direction, but this is also something that we related to that, is that do we want to present something around this initiative for the next regional committee in October? And if we are doing that, it means that by March, max, we need to get something ready, which means what? One would be a roadmap, which basically would be the kind of action plan that we discussed with a set of activities. We need to look at the strategic objective, actions, and we have a short document that explain basically the situation of the region, the current capacity, and what we are proposing as an action plan. This could be a paper that will be presented at the regional committee next October. The communication part, the film, whatever you would like to do, a policy brief, would be into that package. So basically you go to the member states and you have a session specifically on that and you present your approach. It can be this year, it can be the year after, you might lose a bit of time, but if we don't feel that we are ready to do all this, we can also give us a bit of time. But
I was thinking maybe you want to plan first a side event with the regional committee.
Yeah.
So it's something easier.
it's less, it's less formal, and you don't have endorsement.
And
things.
afterwards, eventually,
Yeah.
you put this on
Definitely
the
something, I think, in October, just to keep momentum going and give us some goals to aim for, but make them, reasonable. And then
No,
also
not this
plan
October,
for
there's
after that.
So next year, so October 2020, aiming at having a side event at the regional committee. Okay, would be more.
Yes, you need to link to the agenda.
Yeah, this is why I'm saying March, because usually the regional committee, we have a committee that discuss the program of next year regional committee in February already.
So even if you don't have an item on palliative care on the agenda, you can link with PHC or whatever other item.
Yeah, but the side event, this is something that we need to defend quite. It's not always easy to get in the agenda, even if it's a side event. Like this year in Iran, there have been a lot of competing agenda. But I think if we already make a proposal of a side event, it is something that we can advocate, and then I'll get back to you in spring to say, okay, we are there, we are not there, but at least we can prepare.
Is this something that the regional office pushes for, or do we need to advocate at the governmental level to push for?
It's better if you have, if you have a couple of member states saying we are going to sponsor the.
I can try to figure out who are sitting on our committee for the regional committee, because they are representative for the Ministry of Health from a couple of countries, and they tend to change. This we can check perhaps, and so that there is a kind of lobby behind to say, okay, maybe if you can raise it as part of the agenda items, and you have been aware that there is an initiative ongoing, and we would like to see if there is maybe a side event. Why not? Yeah.
Or if there's no obvious candidates who are obviously on the committee now, maybe maybe people in this room could contact their ministries of health to propose that they support them, depending on who's on it.
Last year, that Lebanon, Qatar, Iran, I don't know how part of the subcommittee do they change annually? So it might be that it's the same.
On the costing aspect,
So, question, the Lancet Commission data, 2015, not 1990, 2015. And it's possible with some extra work to figure out the cost in 2015 of providing palliative care, the needed palliative care to everyone in each of the, to providing the essential package of palliative care to every one of the countries represented here, every one of the countries in the region. It would take, there would have to be a request made to the chair of the Lancet Commission, Commissioner Moll, and it would probably take it will take some time, so it probably takes some money to buy the time of the people who are most familiar with that database. But would it be useful to be able, and this would be a publication, to publish the cost of the essential package for everyone in need of palliative care in the Emira region, by country by country?
We'd like to link it to what we were discussing about the minimum service package. Is this something that is defined? We have an agreement on that? Because the costing has been made on
Intervention. Is there an agreement of the set of intervention that has been entered into the costing model?
There's actually a very detailed description of the intervention that the large part of which was not published in the Lancet report. Some of it is in the data annex, which is supposed to be online somewhere. I haven't checked since I wrote it. I have it on my computer. But a lot of those details were not published. And actually, as you were just this moment, it occurred to me, this would be an incredible opportunity to publish some what I think is very valuable data that were not published in the original Lancet report. Now, it's 4 years old now. The data are 4 years old. But yes, it gives down to the FTEs, so the amount of time spent for each member of the palliative care team at each level. It's very detailed.
Peter, Heba, comment on that?
Richard?
Sorry, I was just looking at some data then, sorry. Data always attracts my attention.
You were talking to your broker, come on.
No, it's what I was looking at. The Lancet Commission on High Quality Health Systems for Global Health have a whole paragraph saying that the best way to deliver palliative care is in primary care, which is kind of really echoing what you were saying. Sorry, your question was?
But the costing,
So we can figure out the cost of
The data you have from 2015,
of the essential package, providing the essential package of palliative care for every country in the region. And if need be, it could also be, how much time for social workers, how much time for doctors. That's the detail.
no, but my question was, have we an agreement of the set of intervention that are that essential service package? Because or we just use it, I mean.
The Lancet package. I mean, Eric, you were part of developing that, weren't you? And I don't know what the process was.
I mean, there's no sense to extract data of intervention that we are not implementing in the region or are not, the core element that we would input into a costing exercise.
So to be very brief, it's got a multidisciplinary team at referral centers, a small team at district level, nurses at community health centers, and community health workers, which I understand is not probably that relevant for this region, in every community. That's what was costed. So it's not, the upper levels sound like it fits with what we discussed. The home care is not what is going to be typical for this region. But the medicines, equipment, social supports, would probably be about the same. Human resources, not exactly, but probably not that far off.
Okay. We might explore and get back, and so depending also of the resources that would be required to pull out this data and analyze it, and we can see whether or not it would fit into a policy brief or not. I think we can keep it in mind, but perhaps see, what would be the resource, whether it's resource intensive to get this data out and how relevant it is to make our case.
22 countries, it could maybe cost $500 per country to do the work. So.
Well, it's part of the argument we were having this morning, or discussion we were having this morning, that the policymakers, you always want to give them an answer as well. Sorry. The policymakers, it's very wise to give them an answer as well as a challenge, because if you give them a challenge without the answer, that makes something up. And it won't be what you want them to be doing. So we're having this debate in the UK at the moment. Don't go with some of that, how you like to fix it, because otherwise it's not going to be the way you planned. So, we were saying very clearly this morning, there's a big challenge for health systems. They've got aging, they've got acute systems, absolutely bedrocks. We've just found in Sudan, Nile found in 6 hospitals, 47% of beds are taken up by some of the life-limiting conditions. They've got a problem, we've got the solution, and I really think that has to be our approach. We've got the answer for you, and that's really what I'd like the policy briefs to be doing. This is the challenge, we have the answer.
I would suggest that that group, if there's a group now, there's only 2 persons in that group. So we need, I mean, with us it would be 3.
Happy, I would love to be a part
Yeah.
of it. I just don't think I don't think it's very clear what the output.
This is what I was about to say,
I'd
that
like
require.
more clarity before I dive in and commit to this.
No, I mean, I think we not reach that level perhaps now. My point is that whoever would be interested to work on those policy briefs, we need to have a follow-up discussion about outlining what would be the content, what would be the input to develop a set of policy brief, and what each of those policy brief in terms of key messages we'd like to convey from the region. And can we agree on that? And then we can move on and say, okay, for that policy brief, that would be maybe bringing something about the costs. This is what we need as an input for it. We can pull out some information, this and there, but this is what we would like to achieve in terms of messages that cut across what you mentioned. One is highlighting the burden, the challenge, the current capacity, but also providing a set of solutions in terms of this is how it would cost you, what are the interventions we would recommend, and this is how the network actually can bring this forward.
Policy brief on opioids. I see one fellow in the pain policy fellowship sitting across from me, and the method of analyzing barriers to opioid access, it was developed by the International Pain Policy Fellowship, I thought was quite elegant. And so I was a faculty member, Dr. Nachla was a fellow. I don't want to volunteer your time. You know firsthand how that method works. And I think that maybe also could be contacted the people from the International Pain Policy. So Jim Cleary is who.
We can figure out also afterwards.
Jim Cleary, are you talking about? Jim?
Yes.
Yes.
So happy to add money to the group.
To the policy. Okay, Azza?
So now that we have a group, we can think of the time.
To get, since we are not necessarily rushing for the RC, but we have just a side event, I would say by the end of the year, because I'm quite optimistic that at least we have an outline of what we want to achieve with this policy brief, with a set perhaps of input that would be required in terms of sources, whether we have existing data information or whether we need to bring together. And the other aspect perhaps is whether the group feel comfortable to design at least a quite advanced drafts and allocate time so that by early next year, most probably February, we already have quite advanced draft or almost finalized draft of those policy briefs. It is something that seems reasonable as a timeline. And we can already, start to have perhaps a set of webinar discussions specifically from this group for those who are involved, maybe by October, November, so that we can already start agreeing on what would be the content, the outline, and the processes of work. Does it make sense? Okay.
On the opioid, because that would be a bit different, because there's
Yeah.
already and Ibtisam, do you?
As I mentioned, opioid might be one of the policy briefs, but you require
A bit of inputs. So one aspect would be just to make sense of what is there in this survey. I would like you also probably to be linked with our colleague at the regional office that are in the EMP and medicine. It's Adi Nusrat in our part, but also perhaps in HQ. Get sense of what is there and triangulate a bit the information and try to extract what is relevant for the region.
So you know the International Narcotics Control Board, which is
Yes.
a UN agency based
Yes.
in Vienna, has all the data on consumption, and I could define that, but it's complicated. And in the past, the Pain and Policy Studies Group at the University of Wisconsin put that on their website. That website is now a different university. Jim told me just last week that it's supposed to be available very soon. So
Yeah, because I went a month ago and I couldn't find any more the
It's
information.
gone,
Gone.
because Jim moved from Wisconsin south to Indiana.
Okay.
But he says the website may even be up right now. And that's UN data, that's important data for this brief.
Okay. Can we move on the second group element, which were on the health workforce, mainly on the discussion about developing a curriculum. Understood that it has to be second level, multidisciplinary, but still focusing on primary health care as an entry point. Having potentially in the future having something that is specialized program as well, but in the kind of short, midterm, focusing for the coming 2 years on something that would be mainly addressing primary care provider. Am I correct? Yeah?
So an example of curriculum for second level training.
So yeah, in terms of, if we break it down by steps, we need to have also some leadership within the network of people that's okay, this is something I can, at least facilitate and take some lead. Would require that we compile somewhere existing curricula. For adult, I don't know, as you mentioned, there's not much in the pediatric field, so how we...
We have a curriculum for pediatric.
Okay. But maybe something that require a certain time to review what exists, compiling it, maybe putting it on a common database, and we can support perhaps the space where you could share those documents and revise them. Probably having a set of webinar or meetings also to someone present a bit of a summary of similarities, differences, what could be modules that are course, things that you can opt out or integrate, I think, making sense of what is there. And then starting progressively drafting something that would be, like a syllabus for a course, learning objectives, target population, the modules, and some description of this. I heard that, some, I don't know if it was a consensus or not about the format, face-to-face as a core. Some aspect might be a kind of preparatory web-based platform. I think might be something interesting also to have some aspect, specifically if you are using WHO platforms. We haven't used that much. The emergency team, I know, use the OpenWho, but to what extent, we can use our platform if there is something. What I would value is that if we are thinking of something a bit innovative, but not the traditional online courses that are quite boring and you just read, and is to blend it with elements that are more about what you mentioned, Asma, on open massive courses, or something that would take example from our countries, short videos, followed by some questions, but this will require much more development at the stage. But we might think on the future that once we have a core curriculum, that some aspect will be blended face-to-face to consolidate, but having some aspect where you are also bringing experiences from your countries. And if you have short videos, a quiz, a set of principles that are something as an electronic database on who diffuse, across our countries, it would be very nice to have that complement. We are maybe not there, but as a starting point, perhaps focus on the development of a core curriculum. So who would be interested to be part of this group? Yes, Iman, Nahla, Asma, and Atif.
And I can contribute the curricula, but
of course.
I don't want to commit to too much.
And think about, I don't know them enough, the colleagues who are absent, do you foresee where they might also fit? Bushnak. B. To Egyptian now.
But now we're making promises on it, perhaps.
No problem.
That's all right.
We are in contact.
Mohammed's fine.
So for that group, are there other things that, at least for the coming 2 years, that you have projected? Yes, this is part of the dissemination of the course. that would require another aspect that we need actually to think a bit more about how we initiate the policy dialogue at the country level and identify the sites. Is there sites that are already providing palliative care, or are we thinking of, I don't know, you said you don't like demonstration site, but I don't know how to call them, a site, the country site where this would happen, and whether we link this into a kind of integrated model where there is training, support, opioid availability, all the readiness is linked, and then you have aspect of support to look at the quality and the change before, after. I don't know how this relate, because we might train, but then we need to link it to the other aspect that will come under the service, the quality assurance. So how you evaluate basically that any change occur after you have made some support to the training. This is not clear to me, is that you can have a very nice training module, you train the people, but then what happened? I think the selection of the site would be important, but also how you are going to monitor the change occurring in those sites. Or
If one of the prerequisites for somebody to train is to bring a letter from their working place, that he's going to be trained in palliative care, and that the administration is supporting his training and is going to allow space for him to practice the palliative care.
but is it at a meso level, or is it at a macro level? I mean, at the government central level, or is it at the facility level? The center.
So then they come, they train, then they go back, and then they can be a follow-up, what they have done, what is the problems they're facing.
If you have someone from a private institute or public,
Possible. We train people in private institutes, and the director was very interested to have a palliative care service. In fact, it's a psychologist who's leading the service.
yeah, I mean, for us, I mean, there is some consideration from a WHO perspective that, I mean, of course, if you are training people and they work in the private sector and they charge for the services, I mean, we need to have a discussion with the ministries about how actually this is organized. This is why I was asking, is it at the meso level, at the facility, or at the central level? I think it has to be linked with the policy dialogue about having a plan for that country that we are offering this as part of the public sector. Otherwise, all the financial protection, the UHC, and all the discussion actually doesn't make sense. So I think it would be careful that we don't have, I mean, then a demand of training that are coming from private sector or from, I mean, people that are working in the private sector without consideration about how this fits into the government entities.
It's difficult if we train somebody and then they shift to private sector. What
Yeah.
can we do?
Yeah. No, of course. Yeah, there's no.
I'd like to add someone in the curriculum from
Yeah.
Egypt, Sami Sarafi. He developed
Yes,
the
Sami.
curriculum in Qasr al-Aini Medical School, and it's implemented, and he's very good.
This might be a little bit late, but I think relevant. For the type of training that you've proposed, your group has proposed, this would probably, the very same course would probably fit into curricula for training special postgraduates in a number of fields.
Yes.
And some countries may have only specialists, some countries have both specialists and subspecialists. But may I suggest that while this curriculum be used exactly as you say, that there be an effort also to request that this course become a required course with an examination that must be passed for all specialist trainees in oncology, hematology, internal medicine, pediatrics, geriatrics, critical care. Sorry? Family medicine, sorry, absolutely. And, you know, some infectious disease.
That's great.
Okay. So the selection of the site, policy dialogue, plus the development of the curricula. I think we are done with this group. Are there other elements that we missed? Okay. Now, the third one on services have mainly two components. One was the model of cares, as we discussed, and perhaps defining the minimum service package. I don't know if there's an appetite for this within the network, understanding what are the intervention first, and beyond what I mean, the third group when we presented, of course, there is aspiration about what we would like to see and what actually we are doing to see this happen. And I was wondering whether one of the elements about the intervention themselves across the continuum of care and the different level of care, I don't know if there's something that could be done on that. The other dimension is the multidisciplinary team and the role and function of various members of a team. If this is something that has been codified somewhere or where we can make some recommendation. We mentioned that we would like maybe to already take stock and share what the country are doing in terms of model of care and present it maybe whether in a journal article publication or a small leaflet. It can be maybe aspect of the policy brief so that we link it with existing model of care and experiences from the region. This could be potentially an entry point. And the last one was on the quality assurance. I was thinking of two elements. One is to have a pilot of some of the existing, maybe simple indicators for the quality of palliative care services, as you have been doing. I mean, and maybe Professor Harding can help us on that point. And at the same time discussing, because this is a global good, so it's something that the colleague from HQ are considering, is to have some kind of agreement or our contribution to a global effort of setting up or identifying a set of quality indicators that might include, I mean, patient outcomes and so linking actually the two processes together so that for the project, if we are integrating all this together, we might have a certain number of sites where we are expecting some change to occur. The training would be there. We might look at the access to medicine and see what can be done at the policy level, if this is what is hindering, and all the kind of system lens that would be the readiness. I was wondering, nobody mentioned it, but we do a lot of this in WHO, is when you look at the bundle of services, you look at the health systems element that would require that we anticipate this in terms of the readiness of the services to be able to be implemented effectively. And I don't know if there is a tool or something that could be done at the facility level before you start. Okay, look at the dimension. Service delivery organization and governance at the facility level, aspect of access to medicine and availability and supply chain, health workforce and the team, what are the team that is there, what kind of training do they have, the health information system and the indicators that we will be using. And you present this as a package for the facility support. So basically the project proposal will come for each of the facility. These are the elements, and you can have a kind of checklist to say, okay, this is done. We have trained X number. This is the plan. The availability of medicine is not an issue. We have a set of indicators that have been agreed upon, and you move on. But I thought that perhaps this group in particular have quite a large task of looking at the minimum intervention and maybe some aspect of health system readiness to be able to implement them, look at the team and the role and function of the team, and perhaps these two elements of quality insurance, but too much?
Well, collecting data on current availability of the essential services and on the current readiness of countries to implement the minimum set of services. It sounds really wonderful and important information, but it sounds like a big task.
No. I'm not talking about doing a survey of all countries. I'm talking that before you go on the sites where you are planning to do like the training, at one point you'll have to select the site in the countries. You might do an assessment of those sites in terms of readiness. I'm not going to send a questionnaire here, but when you go, perhaps you might mobilize some of the members of the network. You say, okay, we have in Sudan 5-6 sites that we would like now to implement changes. The people have been trained. Let's get a bit more granular about paying a visit. We have maybe a checklist of elements, and we have an indicators that this is what is happening on T0, and this is what happened after.
Specific site.
Yes. So it's more a checklist maybe for site readiness that would look at the dimension of health system requirement in order to implement them in the changes. So who would be interested to be part of this group? Nobody. Huh?
The remainder of the people who is not listed there should be in.
Yes, exactly.
organizations, we can think of also countries that have
Yes.
examples to present.
So Sami, by default, you will be part of this group. Given the experience that you have in Saudi Arabia, I think it would be important that you are part. Yes.
And I would add that in the last commission, we also did a series of case studies. And linking to what Hiba said earlier on, we tried to do studies of palliative care models that worked and those that did not. And they've never been published.
Richard, if I may, before you leave, on the quality and the indicators.
So, in addition to the policy piece, I'd be very happy to input on the clinical on quality measurement from that perspective. So, really happy to contribute there. In fact, Mary Charlotte, that is in my work plan, so it's all appropriate, I think.
Yeah, and of course, I mean, Mary Charlotte, since it's also linked to the global good for the last line, you can add her as well.
This indicator work, maybe I would like to have 2 or 3 volunteers from this group to be part of the initiative we are conducting in HQ. So, for example, preparing this expert meeting and contributing to this meeting and follow-up.
So, you have some volunteers on which part? So you can add Iman. Okay.
I'm happy to contribute our model.
Model, yeah.
As well.
On the quality.
Not on quality, on case.
On case studies.
I'm just telling the case studies.
The case studies?
But I'll be
Yeah. Don't want to overburden.
What's his name first?
First.
Yeah.
Dr. Reda.
I would like to participate in for models of care. But
Yeah.
it will be, a theoretical approach, not real one, because I don't have it in reality. To make a comparative study between those that got the care properly at home and those that did not get it, only got it at
But perhaps there are some lessons learned from what you are implementing in Egypt in terms of, pediatric palliative care, because we haven't much example, actually, it's only one.
Yes, which one I can use with
You do have?
pediatric, yeah. So 2005 we started.
Yeah.
Okay.
We forget to put actually the intervention, early intervention, because what is being applicable all over in Egypt and everywhere mostly is that we interfere late.
Late, yeah, of course.
So we should have put it actually that we should interfere from day one at diagnosis as an intervention. We didn't put it. I'm sorry.
No, but the point with case studies is to just document what we are doing. But if we put it in a publication, there are a set of recommendations that might come as a conclusion or something, whatever in a policy brief. The early intervention or it's basically all about promoting more, palliative care, mainstreaming in our countries. So for sure, this is part of your recommendation or something, but taking just stock that, before this meeting, I never heard really much about palliative care for that specific population. So I think if we can start documenting it, it would be good. If we have a couple of countries that have some documents. Do we have in Morocco as well for les soins palliatifs pour pédiatriques? Non.
On prend les enfants, mais il n'y a rien.
Rien de spécifique.
Les mêmes qu'ils font pour les adultes, ils font pour les enfants.
Okay. We have already a couple of elements to work on. It's quite.
Well, I think the report itself should be an outcome as well.
Yeah.
And it's going to take some effort from members of the team and then require the input of everyone on the team. So I think we should include it as a deliverable. And,
Meeting report.
Dissemination also beyond our group, no?
I think this kind of meeting report is also very important for the internal discussion at WHO.
Yeah.
So the first target is the regional office.
other remark, or before we move to the how the group in terms of organizational structures. Okay.
I'm feeding people here.
Yes.
It's holding on.
Okay. Yeah, of course. Yes.
We have a half-hour schedule.
No, I just wanted to mention, are there people that have not been attributed to the group? Ideally, you should all be some part, at least in one of the group. I mean, Samaha, where would you think you would be able to contribute?
Because I'm sorry, that's about that meeting of expert, and I just want to say that I'm a pediatric oncologist with some knowledge about theoretical knowledge about palliative care. So the whole talk is new for me. So I'm just thinking, what can I do to help to put my country in this position? So I was thinking it's all of I was thinking of availability because we have in the Ministry of Health, there's a lot of budget, but you need some person to influence the police maker in the Ministry of Health. So I was thinking about case study and budget and avoid availability of jobs. Training, why don't you come to training? Training, because I have no background, I don't think, I think there's also curriculum, but I have no basic background.
Yeah, but this is also, I mean, the advantage of this network. I think we are all, I mean, I'm an internal medicine specialist. I'm not, but we are all contributing and we're learning also by doing.
I just want to say before I give you advice, that one of the things we've talked about is that there is a lot of expertise around this table, and we do want to speak to the whole region.
Yes.
So please don't feel that the fact that you don't have palliative care in Iraq puts you at a disadvantage. I think you have expertise in pediatric oncology and the palliative care that you are providing, and the context in which you work, which is not really represented around this table. We were hoping to have Palestine here, and we don't. We don't have anybody from Syria here. The context in which you practice includes humanitarian emergencies. It includes a country that has multiple ministries of health. It includes the fact that you don't have resources. And this is very valuable information that you're bringing to this group. So I think you are actually an advantage, not a disadvantage.
Maybe I'll just jumping between the options. I want to, when I ask you about the advice, because I just want to choose something that I can do.
If I were you, I would probably go into the policy. Because you represent challenges to policy, and you can kind of keep us on the ground when we think we can achieve a lot. But
it is also fit for cases that.
Yes, I was thinking about case study because maybe. So I and the policy and the case study. Both? Yes.
For the timing, we didn't talk about, I know when we were talking in the health workforce group.
But yeah, for the curricula, I know. But do we want to set a timeline, just a preliminary timeline for the curricula?
Discuss leading for each of the, if there is many, and getting the input, or what are the elements that would feed into the process of policy brief development. Like, do we have to collect some data that will inform, like the surveys or whatever? I think for that one, we said that the draft, or quite advanced draft, by end of February would be something that we will consider. For the second group,
For the opioid, you described to me a bit about how you've done in Kyrgyzstan, and it seems to be quite a lengthy process. I don't know also what you look at. One could choose a specific country to look at as an example, or...
No, I mean, I don't know. My understanding is that those surveys exist. We are extracting the data of existing survey. We're not conducting country survey at this stage. We are trying to compile what would be needed to develop a policy brief specifically on the aspect of opioid availability, affordability, accessibility, if you want to add. For the curriculum development, one step is organizing some of the discussion among the team, compiling existing curricula, reviewing them, making sense of what could be extracted relevant to the region based on the setting. So this, time frame of 3 months already from now on to end of the year, at least for the review aspect, and coming out with maybe an outline that would be a kind of regional outline. And then you might have much more time for next year, and probably 6 months or I don't know how long for the proper development of the modules that you might have identified. Which means that from now on is more the review and the compilation, maybe 1 or 2 meetings that could be on WebEx or whatever by teleconferences to agree on who's doing what and what are the sources of data that we are extracting, and maybe having an outline also early next year. I know, I'm asking you. I don't want to. The outline, so the review and the compilation of the existing curricula until the end of the year.
So the curriculum, 3 months, I think.
The development or the review? My point was to say we will...
Develop it by next week.
Yes. Wow. We put you in all the group.
1 month to compile everything. 1 month to compile everything. So we already have... We have people who are doing the training, so we just ask them to forward the curriculum that they have, so we can compile them.
Huh?
I mean, we have also to say our work, probably not very enthusiastic, but I mean, to review all these curricula, we are not free.
No, that's why I was just trying to manage a time frame that is manageable for all of you. Okay. Okay, give you, some time. Let's say that by the end of the year, you have a kind of compilation with a comparative tables that summarize what are the differences and having someone that have nothing.
Remarks on each of it,
Yeah.
which is applicable, which is more suitable for instance, in the region or so on. So this takes some.
And within the first trimester, maybe coming out with a draft outline of what would be the original curricula, and then you can enter into the phase of development and distribution of who is doing what in terms of modules. Okay. For the group of case studies and the model of care.
I said 2030.
Yes, for the SDG goals, yes.
Yeah, I think in terms of priority, the policy briefs, if we're trying to make it for next year's meeting, is higher priority. So on my list of things to do, that would be after the policy briefs.
Yeah.
So maybe by the fall of 2020.
Well, there's nothing, so line 11 is just case studies. What about line 10, which I think is the minimum? Oh.
Yeah, it's within that, actually.
It's within that.
You have to add probably the minimum minimum service package. I was thinking that of the minimum service package and the distribution across the health workers, we didn't touch upon it. I mean, we touched upon it, but we didn't include it in the policy, the aspect of regulation for human resources. So basically, who is entitled to do what? And we have a lot of countries going through, like Sudan. They are developing a strategy for human resources at the moment in Palestine as well. So the role and responsibility of different health workers.
Task shifting.
Yeah, and there's not much task shifting happening in the region in comparison to Africa, for instance. But I prefer that. I don't really like task shifting because it's kind of task dumping, but it's more the scope of work and how you expand the scope of work for some professionals. But I don't know if we have that in terms of prescribing role. But as you said, maybe you have almost nothing. Basically, the nurses cannot prescribe in most of our countries. But do we want to include this as part of the role and function, whether the law need to be adapted specifically for palliative care? And if there's any room, like example from Saudi Arabia that you mentioned, that you have the something that's in between.
We start nowadays to license what we call the nurse practitioner. And this is
Prescribe?
to prescribe opium. And this is new event, and the curriculum is written now. And once it's published, I will share it. But it is near soon.
But basically, what I would like to see that what are the team and who of the team is doing what at the moment, if we have it, and what is the law is saying about, because there is something that might be informal or we do it, but actually there is no backing of the regulation, there is no decree that sets what is a health professional is entitled to do or not. I don't know if you can map this.
Yeah, I think, I mean, we can certainly map it for many of the countries. And I think it's very ambitious and progressive for Saudi Arabia if you have nurse practitioners who can prescribe in the region. For most countries, I know that prescription is limited to oncologists and pain specialists, and if they have palliative care providers, those. And so allowing licensed primary care providers to prescribe is something that is necessary to roll palliative care out into the primary healthcare system. So physician prescribing, but not restricted to certain specialties, is something that is essential for this.
But if you want to make that case, then we need to state where we are and having maybe a granular view of what are the prescription rights at the moment and the practice. I mean, we heard from Asma that even from some, I mean, Morocco has an example of caregivers being the right, but there is no backing of the law for that. Est-ce qu'il y a une base légale en fait qui supporte le fait que vous avez en fait la famille qui peut prescrire de la morphine sous-cutanée comme administrée, pardon. Ouais.
Il n'y a aucun texte légal qui interdit, mais il n'y a aucun texte légal non plus qui permet.
D'accord. Et si un jour, je sais pas, quelqu'un fait un arrêt respiratoire suite à une injection,
non, ça n'arrive jamais.
Ou il y a un effet.
Ça n'arrive jamais de faire un arrêt avec 5 mg.
5 mg, ouais. Mais il y a pas de base en fait légale.
Non, il n'y a pas de base légale qui interdit, c'est pas de base légale qui
ça.
permet non plus.
We're talking end-of-life care, and that's probably why it doesn't get to that
Okay,
stage.
yeah.
So we're doing it in end-of-life care, but what about the people earlier on who are having pain? I really think in the atlas, this information is available. We can extract it from the atlas or the data that we collected.
Yeah.
We can use the atlas so we know what prescribing laws are available in all of those, and we can compare them into one document.
So again, I'm not clear, again, whether we're talking about collecting more data on the current availability of essential services, like who can prescribe, or we're just going to use existing data. Are we going to prepare another survey and ask people, or is it just going to be a report of people in this group, or are we just going to use existing?
No, mostly existing data.
Existing documents.
I mean, the only thing that might be, as I mentioned earlier, effort is that if we decide that we have sites where we would like to demonstrate, maybe having an assessment of those sites before starting something.
Okay.
I'd like to make a comment regarding the challenge regarding the challenge we face with the family physician. 2 years back, we proposed that family physicians should take the lead to treat the patient end of life in the community. And we face a resistance from family physicians. They told, we are from previous generation, we don't have the capability to write prescription, narcotic prescription, and nobody taught us. So we generate a new short curriculum. We called it palliative care for non-specialists, 3 months certified and recognized by Saudi information. And now nobody from family physician do prescribe until he have this certificate. And it solves the problem.
Perhaps it might be good in that group that you take stock of this.
Just a comment and a word of caution, because there's a lot of talk about mid-level providers, nurse practitioners, physician assistants. And again, we have to understand the populations that we're serving. We tried to implement this model. We had a lot of resistance because in our population, the number of providers, healthcare providers, physicians particularly, already outweigh. We have so many physicians that there is no role for a prescribing nurse or nurse practitioner, so that model failed very miserably. What Hiba said actually makes a lot more sense, is extending the prescribing privileges for opioids and not just restricting them to oncologists, to anesthesia specialists or palliative care providers, but it should be something that everyone should be able to prescribe as long as they've gone through explicit training. We've got the opioid epidemic in the US, but now the REMS that they're making everyone do, that's a safeguard. So you have to go through 6 hours of dedicated CME that is specific on how to safely prescribe opioids, that leads some kind of safeguards. So that would make more sense.
Yeah. And with the models of care, we have a very detailed starting point, because again, what's in the disease control priorities and Lancet Commission was quite detailed. So that's the starting point of what should be at each level and what the roles of, even what the roles of each provider is at each level.
Service package.
And
Yeah.
the question, just to go back to where you started with this as on the policy level, do we need to do something about this? So just to take it back in terms of deliverables and what we're trying to get out of this discussion is that this should be a priority on the policy level to start working with governments to get them on that page. And we can discuss the details of what training would be required for prescribers, et cetera, but that prescribing needs to be opened up to more physicians.
I was mentioning this in terms of input, whether for the policy brief or for the case studies, or about that level of regulation for human resources, because it's at that level. So I don't know if it's just compilation that is easily done, that we have already the information if we triangulate with the atlas in terms of prescription rights, or is it something that requires additional work? So yeah, it exists.
The data exists. There might be gaps that we need to fill, but I think we have identified leaders in all countries who can fill it in or verify the data. I'm honestly happy to do that.
Okay.
I just start a list and then get in touch with leaders in each country and make sure that verify this is correct.
Because we have also in EMRO our colleague Gulin Fetier, who is the coordinator for human resources. So she's looking at all the elements of production, retention, regulation related to human resources overall. So we might also then, once we have the data, triangulate with her if she has any input to provide on how we would articulate this. Okay.
And for the case studies, we said for the autumn, but they could also be used for the side event during the RCA. They don't need to be finished by February, but maybe beginning of the summer, so they are also
Well, I think Dr. Al-Shamari's will be finished by the end of today, no? How about that?
Yeah, if we can just perhaps, yes, squeeze it in case we can have maybe a publication or something that might be linked to an event with the case studies, a policy brief, it would be a nice package. So we're just saying that perhaps the timeline for the case studies, rather than autumn, if we can still consider that it might be one of the input for the RC. So basically we can say that in the early summer, June or July, if we can get something ready and a couple of case studies that could be whether a publication as a journal article or even something that would be a leaflet.
Or even a special section of a journal on palliative care in the Middle East. We could, if we're going to do that, we would need to contact.
They have a journal, they have the Eastern Mediterranean Health Journal.
Yes.
We have like a dedicated issue.
Yep, I mean, we can ask for a supplement. It's not always easy to negotiate, but we had one on NCD, we had on tobacco in the past, and then we have kind of editorial guests that are responsible of putting together all this, and it could be, I mean, a certain number of articles that have commentaries, that have case studies, depending of, so we have, I mean, yes, I can send you, I mean, what would be an example of a skeleton of a supplement of the Eastern Mediterranean Journal. And this could be, I mean, something, but it requires a bit of work in terms of having an editorial team that's okay, we're committing to do that, and they have some.
To have it in a general medical journal rather than a palliative care journal would be really good and worth the work.
Can explore.
That would be really good. So often this is in palliative care journals, which is preaching to the choir, as we say.
And we don't go for coffee breaks in the fire department.
Okay. Just a meeting report timeline, and we are done.
Okay.
Tomorrow, no.
October 15th.
No. End of October, because we have the regional committee coming in 2 weeks, so end of October.
What rotation are you on next?
Well, I'm here during her rotation, so it's pretty late.
Okay.
No, but you're not alone. We are also part of this, so this is for us.
October 15th?
You commit.
The first draft for the rest of us to review, right?
Mm-hmm.
Yeah.
Okay. A big applause to yourself. So, so before we skip the coffee break and the alarm starts ringing, you have, when do we resume? 15 minutes? And we are back to discuss more how we are going to organize ourselves in terms of a network.
Yeah, and you're writing it, by the way. Yeah.